Well, good afternoon. Thanks everybody for joining us. I know folks will still be joining into this presentation. So since it is recorded, I figure that we're not going to do any harm by getting started on time. Thank you again for being here. My name is Jeffrey Bennett. I'm a pediatrician, a pediatric hospitalist, and my background in terms of quality improvement, patient safety is in the domain of Lean Six Sigma applications in healthcare. And I have about 7 or 8 years of direct experience within healthcare settings applying these models. So this past year with Dr. Court's anticipated retirement, I was asked to join the UT-COM team in support of meeting clear objectives, CLER, with respect to patient safety and quality, which is a wide set of aims meant to provide education, support, and practical use of these models of care that have emerged as a centerpiece of modern healthcare. So I titled this project Simpler Quality Improvement. And this is really in response to some of the learnings that I and Dr. Four have had as we've gone to all of the departments, spoken with department leadership, program leadership, and learn some of the rocks in your shoes, learn some of the challenges you face. And hopefully today we'll be able to make some headway in resolving some angst and making this seem more doable. I want you guys at the end of this conversation to have some useful knowledge and skills. And so without further ado, I'm going to move on. Just so you know, though, if you want CME credit, please do sign into the chat and pay attention to the chat because Bill Reynolds is entering some key information there to acquire your CME credit. So pay attention to the chat box for that. So what I'm hearing around the departments is a lot of very valid concerns. First of all, time is always a barrier, and this did seem like to many folks an added requirement for program fulfillment, for meeting graduation goals. So this is a very understandable concern. Also, the sense of not having at the elbow help when things get bogged down, when you don't know quite how to take the next step. The fact that IRB is part of this process has for some folks felt a bit overwhelming or daunting. IRB has been doing work to simplify the model for administrative review, and part of what I'll do today is share the updated model on that. And Stacy is on the presentation as well, Stacy Hendricks, in case there's other things that she might add at the end. Research as a QI model certainly is definitely about kind of the same thing. We're trying to make things better, but with respect to meeting the graduation requirements, we do need to focus on specific methodologies that you can learn and deploy wherever you work. Publishability is something that people have perceived as a barrier, but within every specialty in medicine, there's been a growing capacity for publishing descriptions of quality improvement efforts. And this is also displayed in annual meetings for various societies. So I believe that that is a diminishing challenge, albeit if you want lead journal publications, you do have to have some fairly astonishing work. And then really not knowing how to get started. Frankly, that to me is the biggest deal. If you don't know how to take the first step, the journey seems impossible. So today I'm hoping to make a little bit of headway with that. So specifically, here's what you need to know as to one of the main drivers why we're having you here today. This is a program requirement now. What was a clear pathway model to introduce and hopefully cement quality improvement and patient safety practices into everyday practice in your clinics, in the hospital, in your learning experience, has now been transitioned into common program requirements. So every program is now going to be required to show progress with respect to this curriculum and its effects within your clinical learning environments. So really none of us is given the choice of saying no to this. While that sounds a bit overbearing, it really is, I'm going to make the case that it's actually much more than that and much more important than that. And so hopefully at the end of the presentation, you won't quite feel so penalized or punished. From an aim statement perspective, we want to make this whole concept a bit simpler so that it's navigable, it's approachable. I want you all to be able to cleanly differentiate quality improvement methodology from research methodology and understand really the purpose of this QI requirement within our system. From a competency perspective, I want you to be able to leave this with a better understanding how to frame a project as an idea comes to mind, and what are the forward steps toward doing that. And then we really should be able to make tangible, positive efforts in introducing a project at Erlanger. And so I want to walk you through the steps of being able to do that here within our system. So as I said at the beginning, there are many, many, many things we do that are oriented toward finding better. Basically a better way of taking care of patients, using our resources, using our talents. And they don't all involve rigorous data, rigorous analysis, rigorous protocols. This schematic basically frames that for us. And what we're going to be focusing on mostly today is the things that are within that QI domain that don't qualify as research. There are things that are QI and research. There's research that's not QI. And at the end of the day, yes, we're all trying to make things better. There are things that fall outside of data-driven efforts or systematic investigations that are still aligned with making things better. Tons of administrative activities behind the scenes are really designed to make our clinics flow better and our operations perform better. So they're not all basically one thing, but they all have a common goal. Separating human subjects research from quality improvement has been a little bit of a stumbling block in terms of making progress. So in shorthand, I'm going to try to make sense of this. And if you want to, take a quick screenshot of this slide because it's a good reference point in case you have some confusion later on. Generally speaking, in terms of human subjects research, your aim is to create generalizable knowledge, which means new findings, new discoveries, new applications that are potentially useful to others, but require very strict protocols to ensure that you're understanding the benefits and risks of that model. So your starting point is really it's really through testing a hypothesis. And you're doing this independent of the routine care platform. So you're creating new work. Yes, sir.
Excuse me for a minute. I'm not seeing your slides. I'm seeing a picture of your open window, but not any slides.
Let me stop share and see if I can reshare. Thank you for that awareness. Let me see. What do you see now?
All I see is your, opening screen.
Your desktop.
Yeah.
Yeah, we're not seeing any slides, Dr. Bennett. This is Stacy. It's just your desktop.
Isn't that fun? All right, hold on a second. Let me back up a little bit. And let's see if I can figure this out. I wish I had friendly neighborhood person to sort out. So what do you see right now? Do you see something that says Stacy Hendricks in big letters?
No.
No.
Normally you have to have the PowerPoint open on your computer.
It is?
Okay, then that's my best. And then usually
let me share that one. Is that working better?
Yeah, it may be.
There you go.
There you go.
It depended on the screen you were on as to which way you could share it.
It just assigned screen one differently. So
yeah, that's
apologize.
exactly what happened. Yeah.
Are you guys, now you're seeing it?
Yes.
All right. Okay. Okay. So did you see the previous slide that had the schematic? I guess not.
No.
No, sir.
Okay.
We haven't seen any of them.
Oh, okay. Well, all the other ones were really just what I spoke to. So I'm not going to necessarily go back any further than that. Those are the goals of today. And this is the schematic I referred to that describes all the ways in which organizations put effort forward to make things better within operations or within the healthcare domain writ large. And you can see that research and QI kind of dominate the data-driven world of trying to improve things or better understand things. They're both systematic in that sense. And then there's a lot of things that may utilize patient data, may utilize other resources, but may not necessarily be project-oriented or hypothesis-driven. So I just wanted to make the case that there's a lot going on out there that you variably may be involved with that are meeting perhaps the aims of QI education, but there may be others that per se are not. So that's the whole point of this slide in general. So moving on to trying to differentiate human subjects research and quality improvement. Human subjects research basically is aimed at creating generalizable knowledge through protocols that are conducted independent of routine clinical care in most cases, designed to test a hypothesis or theory. They are rigid in terms of their construction because, you know, basically the ability to test a hypothesis in a rigorous way requires fairly rigid parameters. And so it has a priori models that must be followed if the research is going to benefit the goal. Again, from a patient level perspective, it may not benefit the patient that are involved in the actual protocol, but should, in general, if you're thinking about trying to make knowledge that's useful to people, hopefully, eventually it will benefit people. Interestingly and importantly, it may introduce the participants to very real risks. And for that reason, no subject is obligated to participate. This is voluntary. Sometimes it is rewarded or remunerated, but for the most part, it is considered a voluntary activity. The endpoint of the project is when you have sufficient data for analysis so that you can test that hypothesis. The analysis is, again, fairly structured and pre-designed. And at the end of the day, you're going to either support or reject that hypothesis. As you probably have seen, projects can be conducted and reported years later. There is not much urgency to make that knowledge immediately available at a large level, but there is a sense of obligation that you should, particularly if it was a funded project. So those are really kind of how human research, subject research models are conducted. If you take the quality improvement model and try to differentiate it, you're really trying to implement knowledge that was gained through research activities and other sources of discovery. And you're doing that really in the context of delivering the care. You're not creating a separate or parallel lane. It's feathered into, overlaid, or basically adjusted into the model of care. The design is really about getting to a goal. So getting there may require multiple creative steps, and you're not done till you reach that goal. So it really is not a rigid construct of how you get there. You're basically using things that are known, and you're applying them in very small cycles to determine whether or not they get you closer. The benefits are really to the system process of delivering care. May or may not directly benefit patients. You may have had experiences where things were adjusted in clinic that didn't directly hit the patient, but may have made it easier to provide care. From a risk perspective, there really is no direct risk of harm to the person. However, depending on the data you're utilizing within that model, you may introduce some risk that the disclosure might occur. Generally speaking, it's believed that that risk should be no greater than receiving care in general, and that the HIPAA policies and protections all apply. This is within clinical operations as opposed to adjacent to it or away from it. The responsibility to participate is a component of receiving care. This is a really interesting point, the notion that patients themselves have an ethical obligation to help us improve the care they receive is really an interesting concept, and one of the things that strongly differentiates quality improvement from the notion of research. As far as the endpoint, it's really when you've achieved that aim or have gone as far as your resources would allow. So that really is a very different model. It is iterative, and it may continue in money cycles until you reach that goal, or again, you don't have the resources to add new changes. Comparing the program internally to its previous baseline, its previous standard, or to an external standard in terms of reaching a quality aim is really how you judge success in analysis. And then results should be rapidly adopted. Again, we're doing small cycle experiments, and when we learn something works, we should try to generalize that within that practice immediately, and then move on to the next opportunity. And lastly, we are encouraged to share descriptions of these projects because, again, the methods involved are very generalizable, but some people get a lot of momentum from seeing that it's been done somewhere else, and they might even have some ideas about how they may address some of those systems barriers through reading those descriptions, but they're in no way the same as trying to share generalizable knowledge. So those are some of the big kind of points to take away in terms of separating these things. And hopefully the methodologies that we're going to discuss going forward will help to further cement that in our minds. Generally speaking, again, human subject research, expensive, complicated, slow, possibly risky. Quality improvement should be low cost, very straightforward, fast moving, and there should be no risk, greater risk than receiving routine care. So yes, there are requirements within your program, but frankly, this is an obligation that we all share. And I like how Children's Hospital Philadelphia framed this. Improving the quality of care of patients is a fundamental obligation of healthcare providers. And when we say providers, we mean all of us who touch the patient intending to help them. The QI process involves evaluating and learning from experience. It isn't winging it. We're iteratively trying to improve our systems in such a way that we can know we're doing the right thing and we can share those lessons learned with others. Targeting better is always the goal, but the model of how we do that has been framed by IHI with 4 pillars. Historically, there were only 3. There was better outcomes, there was improved patient care experience, and lower costs. The way IHI and Institutes of Medicine have framed quality is basically through the steep mnemonic: safe, timely, effective, efficient, equitable, patient or person-centered. This captures really a lot of the holistic domains that make for better quality care, both from the experience of care and the outcomes of care. Lower costs, if we're becoming more efficient, should be an expectation. But I think one of the things we've learned over all of the efforts over time in different organizations to achieve these 3 is sometimes it has resulted in undue strain, wear and tear, anxiety, even poor use of providers of care. Exploitation has even been described because, again, some of these things are very target driven, very numbers driven. Hit the target, hit the target, hit the target. Well, guess what? If you're put in that position where you have to hit the target or else, that can be very demeaning. And in a system as complicated as ours, it's pretty important to recognize that when we talk about improved clinician experience, it's just making sense of our everyday activities in healthcare. So an important question for you to reflect on: what does this mean to you in your own practices? And I think Dr. Panda has done an amazing job of trying to frame the humanistic aspects of what we're talking about here. And I won't harp on it, but it is so important that when we're thinking about these efforts to improve, we are taking into account the human factors that are involved. From a quality improvement construct, again, we have a lot of ways to make things better, but what we're focused on with your curriculum and with these activities is that it is a methodology and it has discrete and important steps. So we're talking about systematic data-guided activities designed to bring about immediate improvements. We're not trying to, kick the can down the road in the healthcare delivery in the setting you work in. Now we're talking about things that are done in the care environment by the people, including the patients who are involved in care there, and within their means, utilizing existing and trusted methods of care. We're not doing experiments. We're doing cycles of change. We're adjusting and learning. And then we're aligning that with the broader goal of making care better for all of us, how we experience it, its effects, and its costs. Looking specifically at those QI buckets, the things that we might say QI methods apply to, again, we're ignoring what was over here, that research stuff. We're talking about a different systematic model. If you have QI that is purely process focused, you don't need to look into patients' charts. You don't need to capture patient-specific information to make sense of it. Perhaps it may be a turnaround time for a process. That's a very straightforward model. And typically, IRB does not have much of an interest in that. They will waive it in terms of their oversight. You're not getting into patient stuff. Where it gets a little bit harder is when you do need to get patient-specific information, you maybe need to go into the medical records. And there are some governance and guidelines around how to do that safely. And again, it doesn't mean that your project wouldn't be exempted, but there are some specifics that you need to be aware of. So the IHI model for improvement basically is an application of just iterative learning. It is structured because human beings tend to run amok a little bit. Human beings sometimes have a very difficult time staying within a designed lane, a specific goal. We get excited or we get distracted. So it is really meant to clarify and focus it so that a team of people can partner together to do something fairly quickly and with a high expectation of success. So when you answer the question, what are we trying to accomplish? And this is the specific question in how you're going to create your project. You are going from an observed problem, something that you're aware of that is a gap or a challenge, and you're trying to create an aim that describes correcting it. Once you have that set of elements, then you can go into, well, how are we going to know if what we're doing is making the impact we hope for? And you have to design specific metrics that give you a sense of, are we actually accomplishing what we set out to do? Are the processes involved functioning as they should? And then finally, are we creating unintended consequences? Are we in effect pitching a problem over the fence and someone else has to deal with it? So those are the sorts of things that keep us honest, keep us system focused, and also enrich our partnerships in the work. And then lastly, it kind of gets fun. It's when you create and design and try out ideas. And really, again, I've said this probably in different ways. The idea is to do this in very simple and very immediate ways. One of the axioms that a coach might ask you is, hey, when can you try the first one? We're not saying the first 20, the first 100. We're not trying to get an aggregate data set that reaches a p-value. We're talking about trying an idea that is within accepted practices and seeing if it helps get you closer to that goal. So it's a very simple idea. You're not trying to, boil the ocean. You're just trying to see if an idea plays out, and you're partnering with others to test that idea. So the plan, do, check, act is meant to be rapid cycle. It's meant to be rich in learning. And if you find something that works, it's supposed to allow you to then cement it into the practice so that you can take and hold that ground as you move forward. Submission requirements. So hopefully by now, and I'll pause because I've been kind of racing through this out of a sense of time urgency. And I think the early slide glitch kind of made me feel a little anxious too. I want to pause here before we move on to some of the nuts and bolts and see if there are any questions or see if there are any comments that we ought to share. I'm sliding through the chat. I'm not seeing any questions right now. Is anyone out there?
Yes, sir. We're here. I promise.
Okay. All right. So, okay, maybe a quicker question. Among those who have been on this talk, can you send me a quick yes if you feel like you have an understanding of the basis of what we're doing, or a quick no if you don't? I won't necessarily be able to process that now, but it gives me a little bit of a feedback loop, and it's immediate, just in time. That'll give me a sense if this portion of slides that we've gone through has been helpful or effective. So very quickly, if you've logged into this presentation, please type into the chat, yes, yep, I get it, I'm with you, no, I'm not. And that'll just give me a sense of where we are. And then at the back end, we might be able to clarify some things. So thank you very much. So moving on, let's talk about getting a project off the ground. This kind of gets into the nuts and bolts of submission requirements. And it truly starts with the project charter. We and many organizations out there utilize the IHI Open School to support learning and how to standardize this model within organizations. Most organizations aren't particularly good at this, frankly, at this point. Some are really good at it. Our organization is making progress, but we need a standard internal way of approaching this, and the IHI model is what we use. So the project charter basically frames the structure of getting a project off the ground. It starts with a question, basically, what are you trying to achieve? And the problem statement is the centerpiece of that. Describe the condition you hope to improve. So an example might be, we observe that some patients leave the hospital without follow-up appointments scheduled. Lack of follow-up may be linked to poorer outcomes and perceptions of care quality. So that's why it might be of concern to us. And then taking it a further step. Let's describe this project. What's the current thinking on the activities that might be needed to address and understand the problem? What population do you think you're going to be focusing on? Where will the project be occurring? And what are some of the short-term and long-term visions with respect to what this project might produce? Again, this is just sort of cloud thinking. You're not really tied down to these initial thoughts, but it is starting to create additional structure. So we might say for this idea, we're going to use QI methods. That's a great simple way to say we're going to use the IHI model to investigate the reasons for patients not having appointments at discharge. We will target patients that are cared for by hospitalist team A on the 6th floor inpatient unit. It's totally arbitrary. You're creating a space that you think you've got a team that might be able to make headway. And we hope to improve quality of discharge. That's kind of the big aim, ideally improving outcomes after discharge. Oh my gosh, that's a big global aim. So this just sort of sets in place a mindset around why this matters and how you're going to frame the project within your organization. Moving on, the rationale. Okay. It helps to have a little bit of evidence. And again, we're trying to apply knowns. We're not trying to explore the unknowns. It helps you to structure your project if you can draw on experiences elsewhere. So for this one, we might say, hey, published evidence demonstrates that increased likelihood of readmission or return to the ER when patients don't have their follow-up visits scheduled at the time of discharge. And you might reference a project that supports that. You also might reference some very immediate data that you've collected yourself while you did the work. You say, gosh, last week, we had 11 patients that we discharged and only 3 actually had their follow-up scheduled, which somewhat validates your intuition that this is a problem. Patient experience metrics, HCAPs, identify importance of complete discharge instructions. And our data tells us that we aren't so hot at this part of our HCAPs feedback. So again, we're creating a rationale why this really is important, not only within the operations of care, but why it might be important to the whole organization. Then you're going to even take that a step further. What would be the expected outcomes and benefits? How would this project actually help with respect to those challenges? And so you're thinking about patient level benefits. Again, we're going back to the Institutes of Medicine domains for quality. We might have an example like the process will be more efficient for patients and clinic staff since many appointments can be made through backdoor numbers. We have access to our clinics that others don't have, and more effective because patients will have better assurance that they're going to have those appointments available. So that is a direct linkage to the rationale and how you're thinking you're going to target this project. You also would want to comment on the system level benefits. So you think about what are the system aims as a whole. Cost, always a deal. Reputation, believe it or not, this is huge. If word of mouth is generated through better processes, the system is very, very supportive of trying to make that happen. Risk, if you can mitigate risks, that readmission risk is huge, both financially and reputationally, but also, let's face it, it goes right against our stated purpose. And then there's compliance that could be involved too. Regulators may be participating in the domain that you're focusing on. So if you can make the case, you have a better chance of getting some additional system level support. So always worth thinking about. I wanted to throw this up one more time in case anybody want to take a screenshot, again, just for future reference. Institutes of Medicine since the late 90s has basically tried to frame this for us. This has not really changed much in the last 20 years, though equity has become a much larger part of the conversation. So some of the things that I think we paid lip service to perhaps 2 decades ago are now front and center in terms of how we think about people in the healthcare system. And again, I think Dr. Pan has done an outstanding job of creating curriculum that guides us in that. So kind of the icing on the cake of this initial phase of framing a project is the aim statement. You're going to take all of this stuff that you've packed into your project charter, and you're going to really bring focus to what you're going to try to do. So you're going to specify your goal, exactly what process you're improving, what your measure of change is, exactly what you're measuring that shows that that change is an improvement. You're going to assure that it's achievable. So again, you have to be able to work within a space you have influence and a space that has the resources and support to make progress. So that frames achievability. Realistic. The scale of the improvement should be challenging. In other words, it shouldn't be like a one and done easy fix. It should actually force you to rethink your processes and how your partnerships play out. So it really should be improving the model of care within that space. If it's easy, then why have a project? Just do it. So if it's more complicated, set a tough target. Not reaching the target is not failure. Again, you're going to go as far as you can in achieving that goal within the resources you have. That is worth celebrating in the QI world. So let's make an example of it. We aim to improve the discharge processes by increasing the rate of having all follow-up appointments scheduled at the time of discharge for hospital medicine team 1 patients, I think team A, on the 6th floor nursing unit from 27%, which was what our small sample pre-data suggested, to greater than 80% within 90 days. That frames the whole project. And this is really as far as you need to go in terms of project initiation, application with IRB, other things with respect to the project charter. There are some other details in terms of data that we're going to have to talk about, however. So data and HIPAA come together in the context of when you go into patient records or in databases and you pull what's called personal identifiers. Their conditions, if you have no way of linking them back to the person, having those conditions listed does not create risk of harm. But if in your data set you have personal identifiers, and I've listed them here, there is that potential risk. Now, every day in your clinic, there is that potential risk of releasing or exposing information that is private to the patient and really should not be exposed. And the idea in QI methods is that your project really shouldn't be increasing that risk. So if you do have to collect personal information, or I should say personal identifier information, you will need to have a plan for how that is managed. Again, one of the design features of a QI project, it is done in the clinical space by the people who do the work. So you're not inviting external partners into that space to see that information. You are seeing it yourselves in the context of operational improvement. So HIPAA has created protection for that effort. They have not made that harder. They simply say you have to know where you're keeping that data and that it's protected. No different than the data you have to keep in taking care of patients every day. So if you're attentive in your clinical practice, you're probably not going to run afoul of this issue with respect to a QI project. But if you're taking data sets and you're putting them on thumb drives, other computers, they have to be protected, and you have to say how that's protected. So that's an important feature and something that our IRB reviewers have to clearly see in order to waive a project from IRB oversight. So if we're going to take a high level view of the process, you start with a problem. Okay, what is the source of the problem? It might be a frustration, your coworkers, or your patients. There could be a visible gap to a benchmark. That benchmark may be an external placeholder for what quality looks like, and you have a gap there. You may have a track record of recurrent problems that are reported in the ESAE system. You may have a project underway that hasn't yet reached its target and needs continued work. Maybe you're going to adjust the focus of that work in order to achieve that target. And again, you have evidence that there's a better way. You're going to draw on the knowledge that's been created through other means, and you're going to try to apply it in your clinical practice. All of those are great sources of a problem that you're going to then develop into a project. So as I said before, you're going to start your IHI charter, and you're going to perform that frame and scope. All of those steps to get you to the aim statement. Super important. You have to involve a team. This isn't your team. This is a team who have shared interest in achieving that target. So you're shopping this idea around as you're framing it. This is not sort of sequential. This is all happening at once. You start out and say, golly, couldn't we do better? And you start conversations with people in that space who are touched that work. And you might find that there's 3 or 4 other people who agree with you. Well, guess what? They're on your team. And you guys together can work on framing and scoping that project and creating that aim statement, sharing your expertise and your experience and the data that you have on hand. Measures. Super important. Like I said, you need to know how to measure your aim. It must be specific. You also need to look at the processes involved and identify ways of knowing whether or not those processes are performing as they should. And then, of course, you want to look for unintended consequences. So balancing measures always play out. Sometimes balancing metrics are as simple as how much time it might take. There may be other things that are actually more ominous, like the risk of a patient not getting something that they would have previously gotten. For an inpatient project, you might measure outcomes like readmissions or repeat hospital visits, ER visits. So do the IHI charter through the aim statement and thoughtfully starting to thinking about your measures before you jump into Form J. Form J is IRB's model for being able to intake this project and do the administrative review for waiver. And it has some very specific questions. If you have not created your charter, you're not going to have the necessary information to fill out Form J appropriately. The final step of Form J is the chair of the department has to sign off on what's in it, okay, and verifying it. And ideally, if you're trying to get a project waiver from IRB, there are very specific requirements within that form that have to be true. So when your chair is signing it, it's basically an affidavit of agreement. And that helps inform the IRB administrative review process that up to date, everyone feels that this is a QI project, not human subject research. It's not under Health and Human Services requirements for human subjects protections. And we're going to focus mostly on, are there any data risks? So that simplifies their ability to evaluate. Now, this year, we've gone to an online version of uploading this. So your IHI charter gets uploaded, your Form J completed with chair's signature. And if your chair wants to take the extra step of saying, yes, in my opinion, this is not human subject research, and we have the appropriate safeguards for any identifiers that might be involved in the data set, I feel that this is a waivable project. That's also firepower. So you get that Form J uploaded into the irbnet.org. You will have to create a password, sign in for that, but it's super easy to upload it. Create it first, upload it. And if it's uploaded by 5 p.m. on Monday, Stacy Hendricks will have it reviewed by that Friday. If it comes in a little bit later in the week, she'll have it certainly reviewed by the following Friday. So you're looking at a 4 to 9 day lead time to get that typically turned around. If there's a problem or a barrier, Ideally, you just want direct contract between Stacy and the project team. I will say it is a requirement that an attending has to be the PI listed on that project. So in Form J, it's an attending physician. This is a requirement of our policy. It's not that hard. It doesn't mean your attending's taking your project from you. You can just simply make sure that that stipulation is met. All right, Form J key information, and Stacy is on this, as I said. If I misstep through this, I'm learning as I go. She'll be able to correct us at any point. Everything up to number 5 in Form J is really transcribed from your project charter. It's going to ask you what your project is, who your team is, and some basic information about your project. But when you get into question 5, you can see by the nature of these questions, we're basically asking, is this research? So again, if it is QI, the intent is not to create or contribute to generalizable knowledge. You're going to use generalizable knowledge. You're putting it to work. So you would not check that box. Participants are randomized. Nope. Nope, you're taking the patients that are coming in the door. You're utilizing the clinical platform to do your small cycles of change in real time, and the patients are not at additional risk. So they have not been randomized. You're not doing research. Activities are not normally done. Nope, this is part of the clinical care. It's being folded in. It isn't something that is external to the clinical care. Results will be used to apply knowledge to other programs outside the institution. This is an oblique way of asking again, are you creating generalizable knowledge? On the Department of Health and Human Services website, there is an FAQ around this question, and their very specific information about this is the mere intent to share this within or across organizations, share descriptions of QI projects, is not per se an indicator that you are now doing human subject research subject to IRB oversight. However, many programs around the country still will look at that intention to publish this or to share it in any kind of external way as something that requires IRB scrutiny. And that is true for our organization too. This is an additional layer of protection against unintended disclosure of information that could be risk violating federal statute. So in our organization, you really have to be careful about this. If your intent, though, is not to basically apply knowledge to other programs outside the institution, you're trying to fix something within your own practice, then you can safely say no. Again, project is subject to peer review, designed to be used outside the institution. Again, another way of asking the same question. If you do intend to publish this, if that's something you're hoping to do, then it's perfectly okay to check E. That is all right. Again, you've got the statement from your chair saying this is a QI project. It is not human subject research, and we're taking the appropriate safeguards to protect PHI. And again, they just want to be able to sign off that in that publication process, you have been supervised in an IRB format. It doesn't mean they're going to be more invasive. Anonymity of participants cannot be assured. This is an area that, just like your clinical practice, you employ the same safeguards. You can safely not check that box. If you are taking data and putting it into other environments like a thumb drive or whatever, it just has to be secured. So using your iron key, for example, that is password protected is one layer protection. Having your data actually password protected within it is another layer of protection, and you can describe that in your methodology. And then again, activities involve no more than minimal risk. That has to be true, right? Let me reframe that. This says activities involve more than minimal risk. That can't be true and call it research. So again, this is just folded into clinical practice, and you're trying to improve that model of care using known and accepted practices. So the other key area of Form J is a bunch of checkboxes, and I've kind of given you a cheat sheet and definitions that you can follow. This is reiterating the same questions so that IRB can confidently say this is waivable. Does the activity involve research? Well, we've already said that it doesn't, and here's what would define research, so you can reaffirm that no, it does not. If you check no on the first one, you skip the second one. This is a skip logic step. Will the activity assess or improve a process, program, or system? In other words, remember that QI project that doesn't involve PHI, doesn't involve personal identifiers? If your project is really process focused, check yes on that, okay? Is the activity intended to improve process delivery of care while decreasing inefficiencies within a specific healthcare setting? Again, many of our projects will do that, and this can also be true. So if that's the intent, check yes. If the activity intended to evaluate current practice and or attempt to improve it based on existing knowledge, again, you're applying existing knowledge, so check yes. At least one of these should be a yes, even if the others maybe or no, to qualify as a QI project. If they're all no, then step back and figure out what you're doing. Is there sufficient existing evidence to support implementing this activity? That has to be a yes. You're not trying to create new generalizable knowledge. You're trying to apply knowledge that exists. Is the activity conducted by clinicians and staff who provide care and or are responsible for the practice in that setting? So in other words, you're not inviting outside stakeholders into the practice. If this is QI, using QI methods, that's typically going to be true. So check yes. Are the methods for the activity flexible? Include approaches to evaluate rapid and incremental changes. That is the PDSA mindset. So you're not creating a study protocol. It is not a rigid construct. You do not have an N that you have to achieve. You're not seeking a p-value. You're just seeking things that iteratively get you to that new goal for the care practice. So that should be a yes. Will the activity involve a sample of the population ordinarily seen in the institution where the activity will take place? In other words, are you utilizing the patients that you already see? Yes. Are they in any way going to be harmed? No. So that's a checkbox yes. Will the planned activity only require consent that is already obtained? This again gets back to risk. If you're not introducing greater than the usual risk of receiving care in that environment, you can safely check yes. So roughly speaking, this is what the back end of that Form J should look like if you're doing a QI project that IRB that can safely provide a waiver. And this does set the stage, honestly, for you to safely publish a manuscript or a poster or present this externally. So it's worthwhile. It's also required within our policy structure. So I hope what I've done with this is shown you how to walk through all those steps in a way that isn't overwhelming, that's iterative, that is first step and then second step and then on, and that you could potentially, if you have an idea of a problem right now, you could already start the work. So resources. We are in the process of trying to update our landing page within the UT website for quality improvement. So when you get into our UT College of Medicine Chattanooga website, if you just put in the keyword quality improvement, it'll bring you to this landing page. And I've kind of opened it up a little bit so you can see all of the components. The key ones I'm pointing to, within every department, there are key figures, program directors and quality champions that are updated on this website. So if you don't know who those people are, it's easy to find out. Just go there, open that up, and reach out to them with your project idea. Something that we're learning is really underutilized is requests for coaching. We have experts who do this all the time, know how to do it, know how to help you. So once you've got a project charter being initiated, go ahead and put in that request for coaching. They can help you think it through. They can help your team think it through. One word to the wise, if you're doing this all by yourself, if you have an idea and you're starting the project charter and you don't have a team, you're not doing QI. You're doing something else. It may benefit people ultimately, but you do need to start out trying to have others participating who have they have activities that will affect that outcome. This is a team sport. So you need a team, and ideally you need a coach to make this move smoothly. So those are resources that you should be able to at least start working with as you envision a new project. And then I'll point to the IHI Open School. Interns this year, all of our new learners were enrolled in the Open School. Some programs require you to go through all of the basic patient safety and quality modules through the course of your residency or through the course of your internship. That's perfectly fine, but the modules are also built so that you can use them in a just-in-time way. So if you're going to initiate a project, hey, why not go to Open School and look at the early modules that describe how do you do that? You know, what are the basic steps? How do you answer the questions? And they give you some nice examples that may help you get through that work and create that structure that you're going to need to make a successful project down the road. There are some elements of this that, you know, in going through it, that I know that Kim and I and others will have to continue to buff up, but this is live, it's active, it's just like anything else in QI. We're going to try to make the best use of resources that are available. So if you know of a resource that's helpful and it should be on here, do let us know. We are going to continuously change this, hoping to make it better and better and better. Key points of contact, again, if you know who your program director is, you should. Who your chair is, you should. Who your quality champion is, you might not. Get to know who those people are and start working with them. Request QI coaching early. Stacy Hendricks, the IRB SRB administrator, is a wonderful source for helping you sort out that submission process or any hangups you might have with the IRB net. You can email her and she will get back to you. She's very supportive and she really wants to make this as easy as possible. She has very, very important duties with respect to making sure that we have the proper supervision, but she's not trying to make it a mountain out of a molehill. She really wants to be able to approve that your project is waived and get you moving on getting your project accomplished. Kimberly Judd is sort of one of those backbone team members who knows all the moving parts, is intimately engaged in trying to get this curriculum rolled out, interacting with all of your leadership, and is working on that website directly. So again, if you have need of her services, advice, or if you have ideas, she's a great person to reach out to. And I'm putting myself out there too. This is my personal cell phone number. So yeah, please don't share it with people outside the organization, but it's already on my emails. So I'm happy for you to contact me if you need to fairly urgently, or you can email me or any of these other folks to help out. And that badib is all, folks. We have about 8 minutes left in our time together, as far as I can tell. So let me invite some initial questions or comments, and then we have a few announcements. One of the disadvantages of Zoom is I can't see your faces, and that's pretty disconcerting. I can't wait to have us back together in an environment where we can actually be a team and view each other more intimately. And not to put you on the spot, but learning is a process of doing and engaging, and absent that, we don't really take much away from these scenarios or these meetings. So please do chime in.
Jeff, this is Alan. I thought that was very clear. I think you went through the steps that they need to take. You clarified a lot of areas that needed clarification over the years. So I think this is a real step forward, and I think it was very, very helpful. Thank you.
Well, Alan, I want to thank you for all the groundworks that have made this transition doable. And as I understand it, when you started out with implementing CLEAR within the Department of Pediatrics with our program director at the time, it was pretty much starting from the ground up. And the progress that was made in the department is evidence of your passion, but also your skills. And I cannot thank you enough for all you've done, and certainly helping other departments around the UT College of Medicine system since you went to the dean's office is a remarkable achievement. So thank you. Others who are involved, Dr. Forrest is the DIO and is ultimately responsible for the delivery of this curriculum in the programs and is a great support and resource. So I don't want to diminish his involvement either. He's been actively engaged as I've been learning about what's going on here. Since there don't appear to be any questions in the chat, as far as I can tell, I'm going to swing down just in case I'm overlooking something. I want to make a very quick announcement. I'm handed over to Dr. Panda, who also wants to make an introduction. On the 20th of this month, October 20th, 7 to 8 a.m. is Combined Grand Rounds. And our new Vice President of Patient Safety and Quality here at Erlanger Health System, Dr. Adam Campbell, will present on drivers for healthcare patient quality and patient safety. And I think it'll be a great way to gain insights about his way of thinking and how he's hoping to leverage our organizational strengths to move us forward at a faster pace with respect to some of our shared aims. So I highly recommend you earmark that presentation for your attention. And now, without further ado, I'll turn it over to Dr. Panda to make a very important introduction to us.
Thank you, Dr. Bennett, and I appreciate, if you don't mind, you can stop sharing your screen.
Yes.
And we'll be happy to see everybody on the.
Done.
Yeah, thank you. Welcome and good afternoon, and thank you for the informational presentation, Dr. Bennett. Just want to take a few minutes to introduce Ms. Jessie Kelly, and I'll hand over the conversation to her. But as we have shared many times, we do a very good job preparing ourselves and our students and learners to take care of patients and to take care of their diseases. However, we also know that life happens, and while we are going through medical school and training, and it also happens while we spend most of our quality waking time with our colleagues, and issues come up. We heard the need from each of you for having some skills and resources as part of our ongoing skills training here, and also for personal assistance when needed. So with that, I just wanted to say that we are very excited to welcome Ms. Jessie Kelly into our family, and she'll share a little bit about herself. Jessie?
Hi, everyone. Thanks, Dr. Panda. So I'm Jessie. I'm a licensed marriage and family therapist. I'm really excited to be here. I'm excited to meet everyone and start working. Miss Pam sent out an email not long ago with my contact information, scheduling. If you guys have any questions, comments, or anything, I'm definitely open. There's also a bio in there as well. So if any questions, just please feel free to reach out.
Thank you. We will also be meeting with each department individually. We've already started this morning. Just want to reassure everybody that she has multiple strengths. Your champions from the Wellbeing Task Force and the Resident Advisory Board and faculty are also very much aware of the various topics. So please let us know if there's anything that's not there. We'll be happy to work with you. With that, are there any questions? Any clarifications? And we'll be coming around each department. So if you think of anything, please don't hesitate to reach out via email or text. And all your conversations with Jessie are confidential. And I hope you will believe that. But if there is any feedback, we do need to know also. With that, I think I don't have anything else. If there is nothing else, I really appreciate you giving us a few minutes of the time today, Dr. Bennett.
Thank you, Dr. Panda, and really delighted to have Jessie joining us. She's obviously going to be a huge asset, and one of the things I've learned about you, Dr. Panda, is you have such a great vision, and you think long term, and you move forward in such an amazingly, I don't know how to describe it. You're always moving forward, and so I admire that greatly, and so I want to point that out to all the people that you support, and how fortunate we are to have you as well.
The feeling is mutual, and you know what? We are a great team together here, everybody, the residents, the faculty, the staff, everybody. And I have been here long enough, so I can only thank everybody who's coached me.
I hear you. Well, that sums it up. I'm going to throw back to sharing my screen in case you missed those points of contact. That way, you can capture them real quick. Hopefully everybody's got that. Can you see it? No? Okay, wait a minute. One more step. There we go. That got it? Okay,
Yes,
good.
sir.
So again, take a screenshot in case you need it for future use. Thank you all for your attention. Please reach out to us if you have questions or you have thoughts about other things you might need. And I look forward to seeing all of you out in the quality improvement world. Bye-bye.